Hi everyone, I'm Emily and I'm one of the residents at Nepean, and I'm going to give a talk on the approach to chest pain, particularly. So just an overview of what we'll talk about the causes of chest pain, the varying causes and the symptoms that can help you differentiate between the common, the life-threatening causes, what you should look for on a physical exam, and the investigations you should order and when you should order those investigations for a patient with chest pain in the clinic. So let's start with the causes of chest pain. So chest pain is one of the most common presentations to the emergency department and most common complaints after hours. About 10% of emergency department presentations are for chest pain, and about 400 million different things can cause chest pain. So some things are benign, some things are life-threatening, some things are very rare, some things are common. Your job as an intern is basically to try and rule out the life-threatening causes of chest pain, so acute coronary syndrome, pneumothorax, aortic dissection, and a PE, and to try and differentiate the chest pain other than that as best you can, and obviously treat the underlying cause. So these are the broad causes of chest pain. This diagram is from Harrison, so it's American data, but it's fairly similar in Australia. And you can see that by far and away, the largest chunk of diagnosed causes of chest pain is actually gastrointestinal. So your reflux and your esophageal spasm and your gastritis and things like that. And the next biggest chunk is obviously your ischemic heart disease, which here accounts for about 31% of diagnosed causes of chest pain. And about half of those will be an infarct, so a non-STEMI or a STEMI, and the rest will be either your stable or unstable angina. So ischemia is a huge burden of disease in Australia. About 3.5% of adults have ischemic heart disease, and it's actually the leading single cause of disease burden and death, according to the Australian Institute of Health and Welfare. So that accounts for most of the diagnosed causes of chest pain. Then the next biggest chunk here in this diagram is chest wall syndrome, like your costochondritis, musculoskeletal causes of chest pain. And then all of your other causes, your PEs, your pericarditis, your pneumothorax, all those sort of things are in this little fraction over here. They're not represented on this graph, but there is a very large proportion of people with chest pain who don't get a diagnosis at the end of it, so they don't appear here on this graph. And those people, you've ruled out all the bad things, including, ischemia, all the bad things, and these people get diagnosed with sort of non-specific, non-cardiac chest pain and are often just sent home, especially if it's all self-limiting and resolves. But just be careful because a study done shows that about 4% of patients who are sent home after presenting with chest pain and are sort of diagnosed with this non-specific, non-cardiac chest pain are actually found later to have had an MI at that presentation, and their mortality, the mortality of those patients, is double that of those that have had an MI and were admitted to hospital and treated appropriately. So just a sort of gentle reminder to take all chest pain fairly seriously until you've very clearly ruled out the life-threatening causes. Cool. So this is a not comprehensive but fairly good table of the different causes of chest pain. Includes cardiovascular causes, pulmonary, GI, musculoskeletal, and other. So in terms of your cardiovascular system, things that cause chest pain are problems with your pericardium, like pericarditis, problems with your myocardium, like myocarditis, heart failure exacerbation, hypertrophic cardiomyopathy, and these are all due to a sort of demand ischemia type chest pain. Your valves, issues with your valves can cause pain, including aortic stenosis, which again is a demand ischemia pain. Endocarditis does not present with chest pain, so you won't find endocarditis with a patient that presents only with chest pain. Conduction system issues like tachyarrhythmias and even bradyarrhythmias can all cause pain, again secondary to this demand ischemia, where the supply does not meet the demand, especially in tachyarrhythmias. Vessel issues can cause pain, so acute coronary syndrome is the obvious one, aortic dissection is another pretty obvious one, and hypertensive emergencies can cause demand ischemia pain. Your pulmonary causes include things that irritate the pleura, like pleuritis and a pneumothorax, which will present with pleuritic pain. Asthma can cause chest tightness and chest heaviness. Pneumonia can cause a chest pain. And vessel issues obviously cause pain, so pulmonary embolus and pulmonary hypertension. Lung cancer can present with chest pain, but it's not very commonly the first presentation of cancer. It's much more common in the later stages of lung cancer, especially if it's already metastasized to ribs. The rib pain from METs can be quite severe. GI causes include problems with the esophagus like reflux, esophagitis, and spasm. Problems with the stomach like gastritis and peptic ulcer disease can all present as chest pain. Musculoskeletal problems, obviously rib fractures will cause pain, costochondritis will be painful, and some miscellaneous causes like anemia, which will present with a demand ischemia type pain if you cannot carry enough oxygen to supply the heart. Herpes zoster can present with chest wall pain. It's often very severe, it's often intractable, it's in a dermatomal distribution, and the pain usually precedes the rash in most zoster cases. Cocaine, amphetamine use, and other drug use can cause a demand ischemia type pain because you increase your heart rate, increase your blood pressure. And you can get some other causes like psychosomatic causes in anxiety and especially in anxiety attacks. But this is obviously a diagnosis of exclusion because people with anxiety attacks who have chest pain as part of their symptoms, it often sounds very similar to angina. And you need to be very careful to rule that out before you say it's a psychosomatic cause. That's it. So what are we going to ask in our history to try and differentiate our chest pains? So in terms of the history, the Socrates method I'm sure you're all very aware of and it works really well. So where is the pain? What's the site of the pain? How did it start? What were you doing at the time? What's the character of the pain? Crushing, pleuritic, etc. Where does it radiate to? Are there any associated symptoms? So dyspnea, lightheadedness, palpitations, fatigue, syncope, things like that. What's the timing? So does it only happen on exertion? Does it get better with rest? What's the exacerbating and relieving factors? So does it get better when you lie down? Does it get better when you sit up? Does it get better with GTN? And how severe is the pain? And obviously in your history, you will need to ask about risk factors and past medical history because they will, again, help you differentiate the most likely causes of the pain. So if someone's, an older person, they smoke, they've got diabetes, hypertension, they've had previous cardiac events and they've got high cholesterol, you're thinking definitely this is a high possibility that there is an acute coronary syndrome type picture. Whereas if someone's got recent immobility, if they've just been on a long flight, they've got a DVT, you're probably more concerned about something like a PE. And recent medical procedures, again, could have caused immobility for a PE, but if they've had a recent angiogram or some kind of cardiac surgery, you want to think about vessel damage, so, dissection. So what will the history sound like if it's a cardiac cause of chest pain? So I've got this myocardial ischemia bolded because it's one of those life-threatening causes that you really need to rule out. And there are a couple of types of myocardial ischemia. So stable angina, unstable angina, and an infarct. So stable angina is usually very well precipitated by exertion, cold, or stress. It doesn't last very long. It relieves with rest. Unstable angina is the similar type of pain, but increasingly at rest or in an unpredictable pattern. And an MI the pain usually lasts for more than 30 minutes, and it's usually pretty severe. So people describe this ischemic pain as a pressure, tightness, squeezing, heaviness. It's usually retrosternal and it can radiate to the jaw, neck, or down the arms. It's occasionally epigastric. And you can get some associated features, so you can get some extra heart sounds, or if you're having an MI that's resulted in heart failure, you can obviously see the complications of that. So creps in the lungs, pitting edema, things like that, raised JVP. So pericarditis is another cause of chest pain that's a cardiac cause. The onset and duration can be pretty variable. It can be episodic, so it can come and go, usually preceded by a viral illness of some kind. The quality of the pain is usually pleuritic and sharp. It can be retrosternal and it can radiate. And it's usually relieved by sitting up and leaning forward. You can hear a pericardial friction rub occasionally, but it's usually one of the later signs of pericarditis. It's usually not there initially. You have to wait for the pericardium to get pretty inflamed and angry. So now some gastrointestinal causes of chest pain. Obviously reflux, which usually lasts less than 60 minutes. It's a burning pain. It's substernal and epigastric. It's usually worse when people lie down after they eat, and it's relieved by antacids and PPIs. Esophageal spasm is usually a fairly short onset pain, so between 2 and 30 minutes is the classic. It can be described as a pressure, a tightness, or a burning sensation, and it's often fairly severe. It's usually retrosternal, and the way these people describe their esophageal spasm pain can sound a lot like angina. So again, even if they've got a history of esophageal spasm, be very careful to rule out ischemia as a cause in these patients, rather than just diagnosing straight esophageal spasm, because it can look fairly similar. Peptic ulcers can also present with chest pain. Usually the pain is a little bit more prolonged than the others. It occurs after meals, usually about 60 to 90 minutes after meals, because you've made all this acid to digest your food. You push all your food through the stomach and all the acid's sort of left there. It's usually a burning pain. It's epigastric or substernal, and it's relieved by food or antacids. And then there's the musculoskeletal and sort of psychosomatic causes of chest pain. So your musculoskeletal causes include your costochondritis, which can be pretty variable, often described as aching. It's sternal, and the pain is reproduced when you palpate the area that's affected. So on the sternal edges where the ribs join up with the sternum. Sometimes on exam you'll see that the sternal edges and the costochondrium is swollen or they're warm over that joint, but it's not particularly common. Usually you just get reproducible pain. Some other causes include trauma. Obviously, if someone's got rib fractures, the pain is going to be pretty constant, aching, localized to wherever the injury is, and reproduced by movement or by palpating the injured area. Herpes zoster, like I mentioned before, the pain is usually pretty prolonged. It's sharp, burning in a dermatomal distribution. And you can see a vesicular rash where the pain is, but the rash can appear quite a number of days after the pain has started. So often when these people first present, they've got this terrible, sharp, burning pain, but no rash, and then the rash only appears a little bit later, and then you can make the diagnosis. Some psychosomatic causes. There are lots of different mental health conditions that can manifest as chest pain, the most common of which is obviously anxiety and anxiety attacks. And these people generally describe a tightness, feeling short of breath, sometimes with these feelings of doom that, all sound fairly similar to angina. So again, it all sounds, these anxiety attack type chest pains sound pretty similar to angina a lot of the time, and you need to be pretty careful that you've ruled out acute coronary syndrome in these patients, rather than just diagnosing psychosomatic chest pain, because you really don't want to miss the acute coronary syndrome just because someone's got a history of anxiety. But usually the pain is precipitated by certain situations or certain stresses. But again, angina is often precipitated by stress, and it can be situational. So you just have to be careful with these patients. So let's go over quickly what you should look for in the physical exam for a patient with chest pain. So you should look for, just look at the patient from the end of the bed and get a general appearance, in your head. So what do they look like? Do they look really anxious? Do they look terribly distressed? Do they look diaphoretic? Are they grey? Because those sort of end of the bed assessments can actually tell you a lot about how stable or how sick a patient is. So it's really important to just take a moment to take in the clinical picture when you first get to the bedside. In terms of the vital signs, you obviously want to know, if they're tachycardic, if they're tachypneic, what their SATs are, and you should get a blood pressure in both arms. In everyone with chest pain, it's really easy to do, so you should do it. And you're looking for that drop in systolic blood pressure more than 20 millimeters of mercury that will make you think that you should be really trying hard to rule out a dissection. You should inspect the chest wall for skin changes, including the vesicular rash of zoster. Look for respiratory distress with accessory muscle use, so tracheal tug, intercostal recession, subcostal recession. Are they tripoding? All of that. How do they feel? So have a feel of their peripheries. Are they warm? Are they well perfused? What's their cat refill? Or do they feel cold and clammy and diaphoretic? Listen to their heart sounds. Do they have any extra added sounds? And if so, were they there during your last assessment, or has anyone documented them previously? You should have a feel of the pulses. Do they feel strong? Do they feel thready? Are they the same in both arms? Is there any radio-radial or radio-femoral delay? Have a listen to the chest. So upper lobe, middle lobe, or upper zone, middle zone, and lower zone. Listen for creps. Listen for wheeze. Listen for equal air entry, because these will all help you differentiate various causes of pain. Palpate the chest wall, particularly over where they say they have pain. And if the pain is, very reproducible and it's the exact same pain that they're having when you press on their chest, you're thinking more likely this is a musculoskeletal problem. But again, pain on palpation does not exclude ischemia or other life-threatening causes. So, it can make you think of, it's more likely to be this, but you still need to rule out the bad causes. Look for signs of heart failure, so raised GVP, peripheral edema, creps in the lungs, all of that. Do a quick abdominal exam. Is there a palpable pulsatile aorta? Do they have epigastric tenderness that'll make you think this is more likely a reflux or gastritis type picture? And have a look at the calves, so warm, well perfused, pulses, any signs of a DVT, so unilateral swelling, any rashes, redness, things like that. I'm sure this is a very unnecessary slide. You all know where the upper zone, middle zone, and lower zone is on a chest to listen to. Make sure you have a listen in all of the areas, because if there's a pneumonia down here and you only listen up here, you're going to miss it. Obviously, these are the areas on the anterior chest where you would listen for different murmurs, so your aortic, pulmonary, tricuspid, and mitral areas. I'm sure you all know where they are. It's very easy to skip over it during an exam, and realistically most times you'll get away with it, but if you're really worried about a patient, you should give them a good thorough exam and listen in all of the different areas. So what investigations do we need to do for patients with chest pain? It's pretty easy. There's really only 3 things you should be thinking about doing. An ECG. Every person with chest pain, regardless of what the pain sounds like, should get an ECG within 10 minutes, because it's really easy to do. It's not very invasive. It's pretty quick. You can do it at the bedside. They don't need to go anywhere. So everyone should get an ECG. Most people should get a set of bloods, including a troponin. If there's a really obvious cause of the chest pain, if there's sort of wheeze everywhere and they're feeling short of breath, they've got a known history of asthma, and they presented to hospital with asthma and they're being admitted for their salbutamol weaning, and they've got some chest tightness, you can probably get away with not doing bloods and a troponin. You can probably see how they go with some salbutamol, some Atrovent, or whatever you want to give them for their asthma. But if you don't have a very clear cause for chest pain, most people should get a set of bloods, including a troponin, because again, it's fairly easy to do, and it's pretty good at ruling out the bad things, so ischemia. Most people should get a chest x-ray just for completeness sake. A lot of bosses and a lot of ED bosses will say that not everyone with chest pain needs a chest x-ray, and that's probably true. But realistically, it's not a very big dose of radiation. It's, again, fairly easy to do, pretty non-invasive, and can help you rule out some of the life-threatening causes of chest pain. So, most people should get a chest x-ray. And this is just some examples of ECGs you may see in a patient with chest pain. Hopefully you don't see these very often. These are pretty obviously bad news. So this is an anterolateral STEMI. You can see they've got some ST elevation in V1 through to V6, ST elevation in lead 1, ST depression, lead 3. So you can see that, you know, that's a very terrifying ECG, and you'd be talking to your registrar or your boss pretty quick about that one, and obviously sending off some troponins. This is another STEMI. This is an infralateral STEMI, so you can see ST elevation in the inferior leads, so 2, 3, and AVF. ST depression all through V1 and V3, and some ST elevation in V5 and V6. So that's an infralateral STEMI. Again, pretty terrifying. You'd be talking to your registrar or your boss pretty quick about that one, and obviously sending off troponins for them as well. These are some more ECGs. So this one you probably won't see very often, the S1Q3T3. So you can see in lead 1 there's this big S wave. In lead 3 there's this Q wave and the T wave inversion, which is, you know, that altogether is the S1Q3T3. And you can see there's a right bundle branch block as well. This is the classic finding in a PE, but it's really uncommon, and most patients will just present with sinus tachycardia, you know, like every other cause of chest pain. So the most common ECG you'll see in a patient with chest pain is this, just your regular sinus tachycardia, and it does not exclude any of the causes of chest pain. But yeah, you probably won't see this one. I just thought I'd throw it in there for fun. And this one looks pretty terrifying at the start, so you can see all this ST elevation, but then when you look closer you realise there's ST elevation everywhere in these, you know, lead 1 and lead 2, AVL, you know, V2 to V6 all have ST elevation, and this is very widespread obviously, and I can't really appreciate any PR depression very well, or maybe a bit in lead 2, but this is pericarditis. So this patient will have pleuritic chest pain that's positional. They've probably had a bit of a cough, cold, flu type thing a couple of days ago, a week ago, and now they've come in with some chest pain. So this is pericarditis. And this is some chest x-rays that you might see in chest pain in a patient with very cardiac ischemia sounding chest pain, typical angina, and this x-ray, you're going to be pretty worried that they've got cardiogenic pulmonary edema and that they're going to drop their bundle pretty quickly. So this you'll definitely be wanting to talk to your registrar and your boss about this chest x-ray. You can just see all of the pulmonary edema in that one. And this one will be a patient that's, you know, come in with some sudden onset right-sided pleuritic chest pain, and you can pretty clearly see the pneumothorax here. So all the lung markings go out to this line here, and then there's nothing on this side. So that's a pneumothorax. And you can see the trachea is midline. There doesn't look like there's any signs of tension in this patient. I should say that with the chest x-rays, most of the chest x-rays you'll see with patients with chest pain are completely normal. They're just normal chest x-rays. So in terms of troponins, anyone that comes in with cardiac sounding chest pain should get a troponin, and they should get a serial troponin, so it needs to be repeated in 2 to 6 hours, because often the first one is negative. The heart muscle hasn't yet had time to die in the infarct, so troponin hasn't been released yet. But then if you remeasure at between 2 and 6 hours, you'll see the troponin rise in someone who's had an infarct. So it's really important to repeat the trop. Don't just do one. Unless they've had the pain for sort of 12 hours, and then you can expect that, you know, if they've had pain for 12 hours, that some of the muscle will have died already, and that you will see it with just one trop. But if this is new onset chest pain, you need to repeat it. You should also do troponins, as I previously mentioned, in patients that you're not really sure about the cause of the pain. So cardiac ischemia, especially in diabetics and women, you know, which is a lot of patients, doesn't necessarily present typically. So if you don't have a good cause for their chest pain, you should do a set of troponins after your history and your exam. And this is a slide of sort of a summary of what we've gone through, the things you actually need to know. You need to be able to rule out acute coronary syndrome, PE, dissection, and pneumothorax. And so you will get that based on the description of the chest pain, the different risk factors, and what you find on exam, ECG, and chest x-ray. So acute coronary syndrome is usually fairly quick onset. It's usually exertional, it's substernal, and may have some radiation, and it's described as a pressure or a tightness. These people will have cardiac risk factors, which you all know. On exam, it will often be completely normal, but if they've had a big MI, you may see signs of heart failure like CREPS or a raised JVP, CREPS in the lungs, sorry, or a raised JVP. Chest x-ray is usually pretty unremarkable, and the ECG may show dynamic T-wave changes, especially the serial ECG. So if the first one's normal, but these people's, it's a pretty typical history for angina, you should do a serial ECG in half an hour or an hour. The diagnostic next step for patients with suspected ACS is obviously serial TROPS and the serial ECG. And if it's elevated, or they have persistent chest pain, or they have dynamic ST changes, they obviously need to go to cath lab. And the urgency of that angiogram and potential PCI will depend on, whether this is a unstable angina, whether this is a non-STEMI, or whether this is a STEMI. So STEMIs will need to go within 90 minutes. Non-STEMIs can probably go the next day or later in that day if it's in the morning. PEs, again, quick onset, usually pleuritic, sharp, not related to exertion. And they might have a history of recent immobilization, pregnancy, malignancy, those PE risk factors. They may have evidence of a DVT, or they may have evidence of right ventricular dysfunction, like a right ventricular heave if it's a big PE. The chest x-ray is usually normal. The ECG most commonly is a sinus tachycardia, but you can get this rare but classic S1Q3T3. And obviously, if you think that there is a low suspicion of a PE, you can do a D-dimer, the utility of which all of your various bosses will debate endlessly. But if you don't think PE is likely, you can do a D-dimer, and if it's negative, you've ruled it out. But if it's positive, you do kind of commit them to a CTPA. And if you think this patient is a likely PE, and the PE is the most likely cause of their symptoms, you will obviously go straight to a CTPA or a VQ scan if you can't CTPA them for whatever reason. Aortic dissection, another life-threatening cause. Pretty quick onset, usually substernal midline with radiation to the back, and people describe it as a tearing or knife-like pain. They've usually got some risk factors like, Marfan's, connective tissue disorders, hypertension. The exam is usually pretty unremarkable, although you can get the blood pressure discrepancy between the arms. And on the chest x-ray, the classic finding is this widened mediastinum. There is no definition for what a widened mediastinum is, how many centimeters is widened. It's all kind of clinical acumen, what looks right, what doesn't look right. So, if you're worried about a patient having a widened mediastinum, just get someone else to look at the x-ray, because there's no actual diagnostic criteria. The ECG is usually pretty unremarkable in a dissection. They may just have sinus tachy. And if they're hemodynamically stable, they need to go for an urgent CT angiogram, CT aortogram. And if they're unstable, you'll need to find someone who can do an urgent bedside echo. Pneumothorax is the last one you need to rule out. So quick onset, pleuritic, sharp, doesn't really radiate, but lateralizes to whichever side is affected. And they'll usually have risk factors like COPD, cystic fibrosis, asthma, or they'll be a tall and skinny man. They don't often, but that's the classic spontaneous pneumothorax. On exam, they'll have unilateral, diminished or absent breath sounds on whichever side is affected, with unilateral hyperresonance on that side. And the chest x-ray is your diagnostic test. It will show a pneumothorax. ECG, again, will be non-specific. It may show just sinus tachycardia or just sinus. And you don't need to do any further diagnostic steps. If your chest x-ray shows a pneumothorax, that's your answer. So these four are the four that you really need to know, the history and exam that suggests them, and then the investigations you would do to confirm and rule them out. So this is really the stuff you're expected to be able to do. So we've kind of covered the different causes of chest pain, from the benign causes to the life-threatening causes, and covered the ways to rule in or out the life-threatening causes, the PE, MI, dissection, and pneumothorax, including, the different quality of the pain, the characteristics, risk factors, what you'd see on exam and vital signs, what ECG shows, and chest X-ray findings that will all help you rule in or out those life-threatening causes. And I guess an unsatisfying end to the talk is that, reminding you that a large proportion of people with self-limiting chest pain never get a satisfying diagnosis. They're just called this non-specific, non-cardiac chest pain. And unfortunately, that's just the way it is. And as long as you've ruled out the life-threatening causes, sometimes that's all you can do for someone. So thank you very much for listening, everyone. So some vascular and some pulmonary causes. Your vascular causes, again, dissection will present as sudden, unrelenting, tearing or ripping pain in the anterior chest, radiating usually to the back between the shoulder blades. And it's usually associated with some high blood pressure, an underlying connective tissue disorder like Marfan's, and on exam you might see this discrepancy or loss in the peripheral pulses. So a drop of more than 20 millimeters of mercury between arms should raise your suspicion for a dissection in a patient with chest pain. Some other vascular causes include a PE. So again, sudden onset, it'll probably be pleuritic, usually lateralized to the side of the PE, but can be central if it's a big PE. And it's usually associated with dyspnea, tachycardia, tachypnea, and if it's a big PE, you can get hypotension. Pulmonary hypertension is another cause. Its onset duration is pretty variable. It's usually described as a pressure that's substernal or retrosternal and associated with dyspnea. And some pulmonary causes of chest pain include pneumonia or pleuritis, which again can be fairly variable. It's usually always pleuritic pain. It's unilateral, localized to the affected side, and usually associated with shortness of breath, cough, fever, creps over the pathology, all the symptoms of pneumonia. Pneumothorax is another pulmonary cause of pain, usually sudden onset, pleuritic, lateralizes to the side that's affected, and is usually associated with dyspnea and decreased breath sounds on the affected side on your exam. And obviously you should check these people's tracheas, make sure they're midline, because if they're not midline, you've probably got a tension pneumothorax, in which case you don't have very long to fix the problem.